Good afternoon, colleagues. Many thanks for inviting me to the grand round today, and it will be on end-of-life care. It's a huge subject, so I decided to concentrate on the difficult conversation part. And you know that I'm very passionate about this subject, so hopefully we will get loads of learning today. The objectives are, I will start with a patient story, and we will talk about the challenges of end-of-life care, then discuss the do's and don'ts of the difficult conversation, and then talk about some practical skills for skillful end-of-life care conversation. The patient here is one of the patients who attended Conquest Hospital. She's a 96-year-old lady admitted from a nursing home with fever, productive cough, was seen by the GP who diagnosed possibly chest infection and referred her. You can see from the slide that I guess if we have medical students here, you really don't even have to be a qualified doctor to see how sick this patient is. Blood pressure 79, temperature 39, and she is passing pure frank pass through the catheter, which was inserted in emergency department. She is saturating 88% on 10 liters of high flow oxygen. She is very comorbid, diabetes, ischemic heart disease, dementia, poor mobility, recurrent UTIs, falls, the whole lot. She is then seen by one of the trainee doctors who tells us that the patient is a bit more alert. She had probably a couple of liters of fluid in A&E department, but she is grabbing and removing the oxygen. She grabbed the doctor while the doctor was trying to examine her. The blood pressure, despite all the fluid resuscitation, is 80/40, and the saturation is 93% on 15 liters. Very poor urine output. The chest is extremely bubbly, and the doctor's plan is to continue further resuscitation, fast fluids, repeating blood tests next morning, hourly urine output is, if possible, thorough fluid input output. And then under number 5, you can see that after doing all of that, doctor knows that the prognosis is still guarded. So bear this case in mind. When we come to the end of the presentation, I'd like us to reflect whereas I can sense that this doctor really clearly could see that they're dealing with a dying patient. What stopped them to do that end-of-life care there and then, rather than pushing for more fluids, more blood tests, more needles, more observations, no squeezing the cannula on their arm? So what is stopping us? What is holding us back, even though we know that the patient is clearly dying? So I come to see the patient on my ward round, and I was late. I was unfortunately late. It was very upsetting for me. I made a plan. She was clearly dying. I made a plan for hyoscine and palliative medications. I stopped everything, but 10-15 minutes later, she died. She died horrendous death. It was really awful. I never actually managed to make her comfortable. These are the type of hands you see with our dying patients. You can see if the blood pressure of that patient is 80/40, probably even lower when she was first admitted to the hospital. You can imagine how difficult it is to get into the veins of these patients. And as a result, what do you get? You get torn veins, and these are the final hours of this patient, of this poor patient, from warm bed into cold ambulance, hours waiting in emergency department, endless needle pricks for blood tests. It was very difficult to cannulate her, several attempts, torn skin on the hands, catheterized, and then the usual journey from one ward to another, noise, vitals, and she died on her own. So she lived to the grand age of 96, and she was not allowed to die peacefully in her own warm bed in her care home. And if we reflect here, I'd like to make it very clear from the very beginning of this conversation that we are not looking for someone to blame in this. Can I make that clear? It's a system problem which we need to address. Even if we go back to that nursing home and the GP attending the patient, let's face it, this patient didn't become 96 overnight. She did not develop dementia overnight either. She's been in that nursing home for several years. Why we haven't prepared, why we haven't made a clear care plan. So starting at that point, the patient entered the nursing home, why the care plan was not encouraged. Then the GP saw the patient. Then the patient came to an emergency department, paramedics en route. No one's recognizing that we're dealing with an actively dying patient. So the challenges, where are all these challenges coming from? No one wants to talk about it. And let's face it, colleagues, if I go on my ward rounds, and there might be some trainees who go on ward rounds with me, I mean, how long does it take to go on a round and make a diagnosis of pneumonia, chest infection, UTI, you know, and prescribe those antibiotics? I actually timed myself once. It takes me about 12 seconds to prescribe coamoxiclav. It can take you up to an hour and a half to go down, sit down, go through the history, talk to the family, talk to the relatives, talk to the care home, and try to design that care plan. It's time constraints. There is no doubt it's time constraints. And then, of course, difficult to recognize a dying patient. One of my favorite tools, very simple tool, which is used a lot by palliative care teams, is that surprise question. When you see a patient, when you are assessing a patient this afternoon, even if someone of you on call, in emergency department, ask yourself, would you be surprised if this patient died this year or in the next 12 to 18 months? If the answer is no, that patient is end of life. And let's remind ourselves also the definition of end of life care, because a lot of you get a bit panicky. The patient gets better next day and you start getting panicky. The patient is not end of life. Now there is terminal life, which is last days, weeks of life, and end of life, which is defined by General Medical Council as last 12 months of life. And during those 12 months, patients can have a lot of ups and downs, but nevertheless, you need to recognize that they are in that final stage of their life and do all their planning. And then uncertainty of your decisions, you can be seen like you are giving up, but that's all depends on a skillful conversation. Nobody will think you are giving up. It's complete opposite, in fact. I mean, how is it giving up if you are investing that time, speaking to the relatives, rather than just going and prescribing another course of antibiotics and buggering off? So not my responsibility. Whose responsibility is actually to do end-of-life care? Is it oncologists who diagnose now? They've done years of treatment and now the patient is metastatic cancer, you know, there might be discharging from their care. And when the cancer was diagnosed, is that oncologists should have that conversation, or should it be cardiologist who is putting that CRT device in a patient with end-stage heart failure, or ICD device, saying that one day, we will have to take this out? Should it be GP who's known that patient for years and years and years? Not anymore, of course, but previously, the family physician. Could it be geriatrician? Well, there aren't enough of us. Or should it be palliative care? Again, with aging population, and very soon every fourth person in this country is going to be over the age of 65. We don't have enough geriatricians and palliative care specialists to do it. So it is really everyone's business. And the other challenge is not having the skill. So we think that the conversations are going to be upsetting for the patient, but actually opposite is true. And unfortunately, the conversations are quite infrequent. Fewer than in one study, fewer than 1/3 of patients with end-stage diagnosis reported any end-of-life care conversation with the clinicians. And those who did have conversations, unfortunately, the discussion took place in the last 33 days before their death. And 55% of initial end-of-life care discussions occurred in hospital setting when the patient is imminently dying. And conversations often fail to address the key elements of quality discussion. So even to this day, we go and when we have these end-of-life care conversations, we go on and say, do you want dialysis? Do you want to go to ITU? Do you want to be Do you want to be resuscitated? We're completely missing the point. The conversation should be about what actually matters to you. What are the goals of care? I had a patient yesterday on my ward round. She's 76, I think. She's 76 with metastatic lung cancer, metastasis all over the place, extensive hepatic metastasis. She's completely yellow, and she knows what's going on. So I didn't go into the conversation saying, well, what do you want to go into intensive care, or do you want chest compressions and putting the pads on your chest? No, the conversation was, well, this is serious, so you know that. Yes, I do, and I know, we know that. So do tell me, well, what do you want to do? And the first thing she has come up with is, I want to celebrate the birthday of my twin granddaughters, of my twins, she said. So that's the first thing she wants to do. The second thing, the family hired a cottage in Rye, and they're having a big family get together in January. And that's another big thing. And of course, Christmas. She would like to do Christmas as well. There are three big things outstanding which she would like to accomplish in the next 3 to 6 months of her life, maybe less. And to this, I replied, of course, we'll try. We'll try to extend it for you. Let's do the scan. Let's see if gastroenterologist can stent you, help this jaundice. Let's see what we can do for you. By the way, the General Medical Council does mention that if you are having an end-of-life care conversation, it is obvious, it is the part of that conversation that there will not be a resuscitation. And if you think it's going to be upsetting for the patient, and it is obvious from the conversation, you do not have to specifically go and ask your patient, do you want me to do chest compressions? But that's a topic for another grand round. It's not upsetting for the patient at all. Early conversations lead to better serious illness care. We plan for the future. We improve their goals. We ensure that the patients actually achieve those goals. More and earlier hospice care. All in all, one study showed 50% reduction in the rates of anxiety at 6 months. And there are so many benefits. And the early conversation, you can't see this in PowerPoint, of course. In the first picture here, I have let's see if I can move this. In the first picture here, I have a crushed land. I'm making a correlation for you here to show that if you delay that conversation and just deliver those bad news, you pick up the phone and talk to the daughter of a patient with end-stage COPD that she might not survive as she is being wheeled into intensive care, that can seem like crash landing for that family. And no wonder we're getting so many complaints and people get so upset. It's not a nice thing to just throw that at their patient in the last 24 hours of their death. Whereas what I'm after is the gentle landing, where you get the conversation prognosis at the beginning of the diagnosis. If you are diagnosing someone with life-limiting condition, whether it's Parkinson's disease, MS, COPD, heart failure, you all know the trajectories of this illness. The average lifespan for a heart failure patient, for example, is about 4 years. We know with dementia, it's 7 to 11 years. These are all patients who are entering that final stage of their life, and depending on the disease, the trajectory can be 6 months for some, 6 years for some. But we need to have that discussion early, and do the active treatment. You treat actively, you try to control symptoms, you try to prolong life if possible, but at the same time you prepare the patient for that inevitable deterioration and progression. So when the progression happens, they can see what is happening, and they're open to the idea of early moment of palliative care. And they might have a few hospital admissions, a few intensive care admissions on the route. But when the final time comes, final days, weeks come, they're not shocked, the family is not shocked, they've done everything what they wanted to do, and they accept quality end-of-life care or hospice care. Prognostic uncertainty for us clinicians can seem like, as I said, giving up on the patient. And if I ask you what is the opposite of optimistic, you'd say realistic or pessimistic, but I'd argue that it's realistic. And a lot of us are over-optimistic with our patients. There is a lot of, I'm not quoting research here, but there is a lot of work done out there that's showing that we are over-optimistic at the beginning of these conversations. And being realistic, it's not being negative. It's nothing to do with negativity. It's just having that honest and open conversation with the patient and preparing them for the future. In terms of the responsibility, I think I've covered that. I hope I persuaded you that it is really everyone's responsibility and you can't do what is being done here. There is no easy way I can tell you this, so I'm sending you to someone else who can. And I have had a lot of that in my clinical practice during the pandemic, where I had so many referrals from the GPs who had known their patients, who looked after them for years, and yet during the pandemic they were sending these patients to my clinic to have that end-of-life care, future care planning, respect conversations. They wanted me to do that. End-of-life care is a skill. Now, if you are a trainee doctor or a nurse, any specialist, if you are acquiring a skill, most likely you will be observed for that skill. You have to be done a few under observation. You might do a few on your own before you get signed off and allowed to do that skill independently. Here, for example, I've got an example of lumbar puncture. Yet we expect a FY1 doctors come in at the beginning of August onto the geriatric wards and have this type of conversation straight away with the patients. In my opinion, end-of-life care discussion is a tool. It's a skill. We need to be trained. We need to be signed off before we're allowed. It's our geriatricians or palliative care physicians tool. Like gastroenterologists have their scopes, cardiologists have their angiograms, and we geriatricians have our communication skill tool. We need to train, we need to pay more attention to this conversation. So here I'm offering you 10 key steps for the end-of-life care conversation, and you might take a screenshot or you go back to this lecture a bit later and practice these skills in your clinical practice. So I will go through each one of them one by one very quickly. So pre-meeting planning, you have to pay a lot of attention to this. Who is going to be present? What is the family in front of you? Do you need to have the nurse with you? Do you need to have a specialist? Like if I recently I was dealing with a patient with end-stage Parkinson's disease, and we were looking for our Parkinson's specialist nurse to come into the room with us, and he did kindly come and advised us a lot during the patient admission. I always print out the blood results, scans, echocardiograms visually. It helps the patients to families appreciate where we are with their loved ones. So, for example, if I'm dealing with a heart failure patient, I have the heart scan and I explain to them what EF means, ejection fraction, pumping function, and I explain that it should be over 75%, but it says 15. And visually, they can immediately say, you don't have to be a doctor or healthcare professional. My God, it has to be over 70%, but mom's is only 15. No wonder she feels so unwell. So I do a lot of that. I hand out the results to them with consent, of course, if your patient can consent. Formulate provisional medical care plan. Give realistic prognosis and goals, and you need to, that is pre-meeting, you need to formulate the plan first. Never go blindfolded into that meeting. You have to have a really good idea what you expect from that meeting yourself first. You are not going into the meeting to ask someone's permission for this and that. You are going to actually deliver a clear, concise management plan. These meetings can be very emotional, especially depending on our own backgrounds. And I remember when my dad died of brain cancer at 55, and I was seeing people with similar conditions, come in, and I couldn't help but visualize my father, and I quite often hug and cry with the relatives, and that's fine. That's fine when you show the emotions. There is nothing wrong with that. So you go into the environment has to be quiet, no conversations in the corridor if you can help it. And I do get very irritated when the door keeps opening and closing during the discussion. So do put some sort of sign maybe out there. Have water glasses, napkins, make sure you are fully prepared. Do not jump into the conversation straight away. I mean, a lot of families, in half of the cases, you go into the room with the family and they're so angry. You can see that if they were allowed, they jump onto your chest and suffocate. That's how angry they are. You have to deflate the situation. And I mean, I might comment on shoes or clothes, make a comment about a nice scarf, or ask them about their journey, whatever is appropriate, really, in the circumstances. I'm now fully integrated into British culture, so I talk a lot about weather as well. And that's a very good one, isn't it? If you run out of all ideas, just ask how is the weather out there in your area and so on. So what was said? So before you start bombarding them with the information, you ask them, what has been said so far and by whom? And my God, the amount of stuff I'm getting out of people in terms of what has been said before. And sometimes I do wonder that some of the stuff is so ridiculous, I don't believe it has been said. And in these circumstances, people sometimes hear what they want to hear or misinterpret information. So you really have to take it with a pinch of salt, what you hear. One of the commonest ones is, I'll give you an example where I spent an hour or more with a family. Mom has dementia. Dementia has been deteriorating, and they cannot understand why dementia is deteriorating. And the first thing they said to me is, Mom had a brain scan, and the junior doctor told us that the brain scan is normal. So why is her dementia deteriorating? And I had to go into a huge conversation. One explained that normal scan doesn't mean anything with dementia progression. And two, there is no such a thing as normal scan in a 90-year-old anyway. So I had to pull them back and get the CT scan onto the screen and show that half of the frontal lobes were missing. There's atrophy the patient had, the small vessel disease, and how all of that makes the patient vulnerable, exposed to delirium, dementia progression, and so on and so forth. So find out what has been said. And then, of course, their understanding and expectations. How do you think your loved one is doing? So get them to talk. Don't say, oh, they're not improving. We don't think that they will turn the corner. Get them to talk. Over the last 6 months, how mom has been doing. Get them to tell you the truth. Okay, so a year ago she was walking. 6 months later became housebound. 3 months later she is bedbound. She's been progressive. Yes, we saw all of that. And now she is not eating, drinking, losing weight. They've told you the story. So your job is now really easy. And what are you hoping for? In the discussion, quality. So what do you want mom to happen? So the Parkinson's guy, she said, dad doesn't talk. Dementia is quite severe, but we see smile on his face when he's sitting in his wheelchair and the grandchildren playing on the carpet around his place in his bedroom. He really enjoys that. And the next thing I said to her, that's lovely to hear, but your dad in the last 6 months spent 5 months in hospital with recurrent admissions. So we are not achieving that goal, aren't we? Your dad loves being in his bedroom with grandchildren playing by his feet, but he spent 5 months in hospital. And you immediately can see like a wake-up call to the family. Well, yes, that's true. This is true. That's what we want dad to have, but he's stuck in hospital. Why? And that's how the conversation goes. The medical review. So I then, after all of that, I go in and build that frailty picture and start summarizing medical conditions, explain the vulnerability, the test results, what we've done so far, what we have achieved so far, and what we are planning to do, bearing in mind the goals of care. And if the goal of care for him to sit in his wheelchair and see and hear his grandchildren, then that goal of care will not, the plan, the future care plan will not involve hospital admissions. That patient will be discharged with me writing on that respect form, avoid further readmission to hospital, because readmission to hospital does not meet the main goal of care. Allow silence. So remember to have regular stops, and especially if you've just thrown a really bad news at your patient, they will be somewhere at the bottom. They will sink. And even if you keep talking, they will not hear you. You need to allow them to go down and then come up and get back to you and start hearing again what you are going to say. Reassure that the treatments are not going to stop. We are continuing with the treatments that is, which are there to meet the goal of care. So do remember, you have to have the goals of care. Don't forget to respond to the grief. What I can do for you. Who are you with? Who is going to drive you home? If you are having a conversation over the phone, is somewhere there with you. So try to help them as well. And then transforming the goals of care into a medical plan, and the type of more medical things you might discuss, you have to discuss and put into your future care plan is future hospital admissions and hospital admission avoidance, ICU admissions. Are we going to do more invasive tests? I'm yet to meet a patient who is demanding colonoscopy in the last few weeks of their life. I haven't met one yet. It's us who is doing it to their patients, to our patients. Discuss the procedures, NG tubes, PEG tubes. And I had a patient with a severe stroke. Completely one hemisphere is wiped out, quite an elderly lady who had a PEG tube inserted and discharged for end-of-life care to nursing home, and no quality of life. And with her non-hemiplegic arm, every time they were trying to put something into her PEG tube, she was pushing the nurses away. She can't talk. It was her way of maybe saying, I don't want this, I never wanted this. And the family wrote back to me asking to take the tube out, not to the stroke consultant who put the tube back, not to the GP who is caring for the patient, but to me, not to the gastroenterologist to put that tube in, but asking me to take that tube out. So it all does seem that all the roads lead to Dr. Mucci these days. Anyway, let's carry on. And antibiotics, yes, so antibiotics, we have crisis response team. We need to discuss. The patient is at home, we're avoiding hospital admissions, but we can give, if the Parkinson's disease, another aspiration pneumonia, we can give antibiotics intravenously even at home, if that's what we want to do. Discuss what is the preferred place to die. And in summary, when you are building that medical plan, the thing you should have in your mind is, well, when I'm implementing this medical plan, what am I achieving? Am I improving the function? Is the patient going to walk better or do the activities of their daily living better? Am I improving quality of life, or am I buying the patient more time? What exactly do they want? And you need to discuss all of that with the patient. So the basic rule of thumb, colleagues, is that if the test or procedure will not help towards meeting that stated goal, then it should be discontinued or not started in the first place. So with that patient with a PEG tube, my question is, why was that PEG tube put in the first place? What was the goal of care for that patient with complete hemiplegia, aphasic, and urinary catheterized, doubly incontinent, a pressure source, massive weight loss, over 4 months admission in a stroke unit? What was the goal of care when that PEG tube went in? Why did it go in? What exactly? How we were improving? Are we buying patient more time? Why? Are we improving her function? Is she going to walk better or do things better with a PEG tube? Well, what exactly did we achieve with that PEG tube? And by the way, the PEG tubes at that stage, they do not prolong life really, and they do not prevent their readmissions to hospital. So options. Do not offer too many options. Your options should be, again, based on the goals of care. It is no good to offer in an option which actually medically you don't think it's appropriate. So you might have 2-3 options and they should meet the goals of care. No antibiotics, or have oral antibiotics but not intravenous. Continue chemotherapy, dialysis and blood transfusions, but also refer to palliative care or stop it all. So not for intubation ventilation, but for NIV, for their COPD. So there are always options out there. I wanted to share this trial with you, which some of you might have come across. It's 10 years old, but it's one of my favorite ever papers. It's a randomized controlled trial, really good designed, and the participants were patients with advanced lung cancer. These patients had monthly outpatient palliative care visits starting within 8 weeks of diagnosis, along with their cancer treatment, or they were randomized into the usual care pathway, that is only cancer care. And guess what? Early outpatient palliative care led to better quality of life, better prognostic understanding, better mood, lower rates of depression. As you can see, they're all statistically significant as well. But most important one, which actually I'm sure helped this paper to find its way into New England Journal of Medicine, is improved survival. People in palliative care group survived by 3 months more than people who were just receiving usual cancer care. And if you think about loads of those super expensive, eye-wateringly expensive cancer treatments for metastatic end-stage cancers, they prolong life by 2, 3, 4 months. And here we have a potentially a not that expensive intervention which prolongs the life by the same amount of time. So why aren't we doing it? Manage conflict. And I'll give you a few of my experiences. There could be a lot of conflict in these situations, and I've divided it into 3, the way I see it. So difficult patient. When you are having a bad day with a difficult patient, and I often hear my junior doctors coming, oh, this patient is so difficult. It's not because your patient is deliberately trying to be difficult and upset you and annoy you. No, that's not the case. Your patient is being difficult because when they receive that life-limiting condition diagnosis some years ago, nobody explained to them what it will look like at the end. And when the end has come, it's accelerating so fast that they don't have enough time to absorb and comprehend the information, and they're angry. The patient is angry, the family angry, everyone is angry. And in hospital, we're picking up all these bits of pieces. That is why you come across so-called difficult patients. They are not really difficult. It's a lack of communication, unrealistic communication, maybe from over-optimistic medical teams previously. And there is, of course, a compassion fatigue amongst healthcare professionals as well, which can lead to detachment and depersonalization, depersonalizing the patient care, so just not wanting to have that conversation. And then the next one is difficult families. It's as above, the same. It's a families who just simply do not get that information. And the number of complaints I have dealt in that respect over the pandemic, it's quite unbelievable. And every single complaint is, I'd say 99% of complaints were communication related. I have to admit, I have come across dysfunctional and completely disengaged families, which my junior doctors often call crazy family or mad family. This family is mad. And I have to accept, yes, there are some families out there, but majority of them, it's a miscommunication. The last one is difficult ologist. Now, let's talk about this a little bit, because I have had, in my younger years as a consultant, quite a few fallouts with a single organ specialist, which I regret, and I'd like to share that with you and learn from my own mistakes. So the single organ specialist, whether it's a nephrologist, and we've had so many situations on the ward there, end-stage kidney disease, dialysis patients, they're so frail. They have so many comorbidities, no quality of life. Their kidney unit is insisting on continuing dialysis. Patient doesn't want dialysis now, and you can get into a bit of disagreement. I also had angry moments with the oncology teams who, in my opinion, couldn't see the bigger picture. But let's face it, before we come into the picture, that single organ specialist has been looking after that patient probably for many years, and they have built that relationship. That single organ specialist helped that patient to survive those extra 10, 15 years or whatever. So sometimes they're biased, they don't want to see, for them, it's hard for them to give up. So I totally see their point as well now. I've mellowed though. So I just, if you are a young specialist out there, don't be angry with your single organ specialist. We need to work together. At the same time, I'd like the single organ specialist to also see the point of palliative care, geriatricians, try to see that whole picture of frailty, and us work together and have these conversations. My job will be so much easier, and the patient's end of life care will be so much better if all of us start having that conversation at the beginning of the life-limiting illness. And by the way, do you know that the euthanasia bill is going through the House of Commons? There was 2 readings already. I am very closely following up on that. And if you ask me directly what I think on that, I will be honest with you, I do not know. Some days I think absolutely not when I see beautiful examples of end-of-life care. Some days I see examples I gave here and I think this is horrendous, this is awful. And of course, there are arguments that people should have autonomy over their lives. My strong belief is if we manage to get end-of-life care beautifully done, if we all do our job, then there will be no need for discussion for euthanasia. Right, we're almost coming to the end and we can have a few questions there. What have I done? Do you see these guys? Yes, so we were here, manage conflict. So summarize and document. Documentation is very important. Remember, quite often you will be that interpreter. You will be a liaison person between the single organ specialty team and the patient GP and the patient himself. In my clinics, and I now see a lot of pre-op patients, my colleagues, surgeons send patients to me before the surgery to do the comprehensive geriatric assessment. And I sit down with them and actually formulate the questions. We do the CGA and I say, next time you go to see the surgeon, can you ask this question, how this is going to be done? So we formulate the questions together and documentation. Finally, some of the information and learning I've got from the Serious Illness Conversation Guide, which I really love. It's a really good healthcare resource. It is online, brilliant website, loads of videos, loads of material. And as you can see here, it's a small print, but it has, especially for our student nurses or junior doctors, there are tips on how to say certain things and expressions. In summary, early end-of-life care planning improves quality of life and reduces anxiety and depression in patients with life-limiting illness. The end-of-life care discussion is a skill and requires proper training like any other medical procedure. And that early conversation is everyone's business and must take place at the time of the diagnosis of life-limiting illness. And that is me, colleagues. If you want to now